Up to this point, diversity, equity, and inclusion had not had any designated spot during our grand rounds, and we thought that it was important as part of our training and as one of the missions of the department to emphasize diversity, equity, and inclusion as part of our program. It's one of the things that we believe in the department, and
Yes.
we're taking initiatives to improve.
Yes.
So we want to hear what people across the country that are working in these issues can help us be better and get ideas and develop this kind of virtual think tank.
That's wonderful.
So without further ado, we're gonna start the Department of Otolaryngology Grand Rounds. So the framework for today's Grand Rounds will be a little bit different. We will have a diversity, equity, and inclusion panel discussion. We have leaders from across the country that very gracefully have taken time to be with us despite time zone differences. As you know, there is not a week that passes in this country in which issues of race, diversity, equity, and inclusion are not in the news. Just this week, on Monday, we had Martin Luther King Day. By Wednesday, the voting rights bill failed in the Senate, and the Senate Minority Leader said the following words, and I quote, "African American voters are voting in just as high percentage as Americans." So as you can see, this has been a very slow process of integration and inequality. So before introducing our panelists, I would like to start with the discussion with a quote from Martin Luther King from a speech at Barrett Junior High School in South Philadelphia in 1967, 6 months before he was killed. He said, "We must keep moving. We must keep going. If you can't fly, then run. If you can run, then walk. If you can walk, then crawl. But whatever you do, you have to keep moving forward." So Karthik, introduce our panelist.
Thank you, Tim. So I'm very humbled to be in the company of these folks who are incredible leaders in our country and in our specialties. So let's start off with Dr. Carrie Francis, who I almost had a chance to be on a panel with at AAO. But Dr. Francis is Associate Dean for Workforce Innovation and Empowerment in Faculty Affairs and Development, as well as Associate Professor of Otolaryngology at Kansas University Medical Center. And as well, we want to congratulate her. She's the president-elect of the Harry Barnes Medical Society, which is a leading society that promotes opportunities for underrepresented groups in our specialty. So Dr. Francis, we so appreciate you joining us today. And I also have the great pleasure of introducing Dr. David Brown, who is Associate Professor of Otolaryngology at the University of Michigan, but as well Associate Vice President and Associate Dean for Health Equity and Inclusion at the University of Michigan Medical School. And Dr. Brown is a leading figure in the discussion of equity and access to medical education and residency training, among many other things. Tulio, would you like to introduce?
Yes, I would like to introduce my friend and collaborator, Dr. Jesus Vallejo. He is a professor of pediatrics and medicine and infectious diseases at Baylor. He's also the Associate Dean of Admissions, Diversity, Equity, and Multicultural Affairs, and the co-director of the Graduate School of Biomedical Sciences Clinical Scientist Training Program at Baylor College of Medicine. And another collaborator, Dr. Howard Francis. He's the Richard Hall Cheney Senior Distinguished Professor of Otolaryngology and the chair of the Department of Head and Neck of Otolaryngology and Head and Neck Surgery and Communication Sciences, and a professor at Duke University School of Medicine. So I want to ask a question that is going to go around the horn for everybody. What was the defining moment that opened the door to your leadership journey? So we can start with Carrie, and then we can start rotating the question around.
Sure. You know, I thought a lot about this when you sent the questions, and I think one of really what started my leadership journey was, I think, a bit of a frustration and a turning point as a faculty member when I had the opportunity, perhaps, and the time, and maybe a budding influence and the ability to change the narrative. Really redefine the workforce. I became very interested in really wanting to be what I wish I had seen as a medical student, as an undergraduate, as a resident, more so than I did. And that was a great vision and clarity for me. And then I would offer that I was fortunate to have people around me that sponsored me, not only mentored, but really sponsored me into positions and opportunities where I could gain skills, gain more knowledge, and really gain the confidence to lead. And really that's helped me get where I am today.
Great, thank you. David, you want to answer the same question?
Yeah, absolutely. And thank you. I want to first thank you everyone for the opportunity to be here tonight. I know so many people here through so many different aspects of my otolaryngology career. And so it's such a pleasure to be here. And so to me, my leadership started with kind of my purpose in life. And so I have tried to live a purpose-driven life, and my purpose is to kind of make a difference in the lives of someone or a group of individuals every day. In fact, I feel that if I didn't go to medical school, I probably would have just been a guidance counselor, because I just really want to help people move along in the system. I became a doctor because I grew up first generation, low income, and you go to medical school because it's a sure thing. And I wonder if I didn't have that circumstance, if I would have chosen a different path, or even a path with more risks and potentially different rewards. I'm a people person, and so I like connecting with people and helping people connect with others. And I wanted to figure out how to do more. I was really excited about my training in otolaryngology and pediatric otolaryngology, and really excited to take care of patients and complex patients. However, those of you here who take care of really complex patients and who like a challenge and like to grow, you don't want to, as you're getting older, to always be taking care of the most complex patients and dealing with the most complex situations, yet you still want to contribute. And so I thought about different opportunities that I could contribute and help others. And I benefited from like Dr. Carrie Francis, from having excellent mentors and sponsors. Jerry Healy was my sponsor, and whenever I would need something that I didn't get, it's almost like going home to daddy, and he would fix it for me. And at Michigan, Marcy Lesperance was my mentor from when I was a resident doing research. And even when I left and went to Hopkins and MCW, she was always my mentor. When she recruited me back, I told her that I really wanted to develop my leadership. She put me into a leadership position when I first got back to Michigan, and opened the doors by putting me in multiple areas that would stretch me and teach me things. I have a feeling that at times she did that because she was offloading work to me, but at the same time, it was beneficial for me to grow and develop. So thank you.
So David, you were very humbled. You could have also been a musician. Those that don't know Dr. Brown, he's a very accomplished flutist. So that could also be in the cards. Jesus, can you answer the same question?
Yeah, Tulio, I got interested in this work when I was a medical student at Baylor back in 1985. I was one of 5 Latinos in my class, and you're talking about the state of Texas, right? There were 3 African Americans in my class, a class of 168. And ever since then, I wondered, well, where's everybody else? I sort of went to undergraduate in San Antonio, Texas, where, Hispanics, constitute almost 75% of the population. So I always wondered how admissions committee made decisions as to who to accept into medical school, because certainly it wasn't a very diverse class. in my opinion, and I was just a first-year medical student. So as the years went by, I became more and more interested. I started noticing that not only was there a lack of diversity at the medical school level, there was a huge lack of diversity in the residency programs and in the fellowship programs at Baylor, where you are in a place where you know there's a lot of Hispanic and a lot of African Americans, residents and fellows. So I got interested into this work. I also benefited from the mentorship and sponsorship of a lot of people. One of the major figures at Baylor when I was a junior faculty was Jim Phillips. Jim came from Case Western to Baylor because we were having a major problem in terms of recruiting a diverse medical school class. Jim was one of the very first deans of diversity at Baylor. And so a lot of the things that I learned and a lot of things that I've continued to work on stem from my relationship with him. And similarly to what a lot of people have said, I think that just from being in and spending a lot of time at our county hospital, Bentop, and working with that population, you can really understand why having people caring for you that look like you really makes a difference in terms of the outcomes. And that's how I got into this work. I've been doing it now for almost 12 years. And that's what makes me get out of my bed in the morning and go to work. And especially when you see that year after year, with the hard work of everybody at Baylor, we're seeing more and more diversity in the institution, not only at the medical student level, but also at the faculty level.
Howard, the same question.
Sure, to follow up on what Jesus said, I sometimes forget just how rare it was to see another person that looked like me. In much of my career early on, I was the second African-American at Hopkins resident and the first to join the faculty. And so I was used to, and I think many of us are used to leading. We are leaders, and that is how we get to go to medical school and how we get to lead teams. But the nature of our leadership, at least in my mind, as I look back, was a practice of leading from outside and leading from below. And having some success in doing that, in trying to influence the attitudes of the majority faculty around me, and hopefully influence the environment. And there were small successes as member of the resident selection committee, for example, as a resident and then as a junior faculty in the building of educational and research programs and helping teams sort of define its shared aspirations and develop goals that then could be fulfilled. But I guess I would say that the defining moment, because I unlike many of my colleagues who really saw themselves and eventually did become chairs, did see themselves as chairs from the very first day of internship. Several people made that declaration. It just wasn't something that I saw it just didn't cross my mind. I didn't think it was possible. I don't know that I didn't think it was possible. It just wasn't something I really thought about, and maybe I didn't think it was possible. But I was asked by my chair. I remember going into Lloyd Miner's office, and he surprised me with the question of would I become the program director, the residency program director, and I could have hit the ground because
And we're having some connection problems.
something of that importance. And wasn't there? I'm sorry.
It's back, I think.
Uh-oh.
Uh-oh.
Here he comes.
Howard.
I'm going to, I apologize. I will I'm going to use a combination of my phone and we're having some weather issues here, so I think that probably is playing a role.
Sounds good. Thank you. So
thank you all for answering that question. That's a great sort of entree into the discussion. So what we'd like to do now is we have a question that we wanted to pose to each of the panelists respectively. But after the panelist who sort of gets first dibs responds, then of course we would welcome any of the other speakers to respond as well. So we'll start with Dr. Brown. So David, you know, as you know, it's not uncommon at major medical institutions and academic centers that the highest ranked person from any given underrepresented group is in some sort of diversity and inclusion related role. Sometimes as a dean, as in your case, sometimes in other ways. So we're wondering, you know, can you define your role and the scope? And do you feel like these sorts of positions in a way become a glass ceiling, or are they a segue to even greater, you know, higher level roles that you might wish to pursue?
Yeah, thank you for those questions, because they're all very, very important and very insightful that you asked them. I'm unfortunately not the highest ranking underrepresented person at Michigan Medicine. The chief operating officer is a Black man, and the chief human resources officer is a Black woman. And until recently, our chief of communications is a Black woman. But you're absolutely right that often the chief diversity officer is the highest and only person of color. And many times the even bigger issue is that we don't always have a seat at decision-making tables. We do have titles, but not necessarily opportunities to influence the decisions. The second part of your question was defining my role. And I would say that this is a challenge, because until you actually get into the role, you actually don't know what diversity deans do. We do a little bit of everything. And so, you know, I have the honor to serve as the Associate Dean and Associate Vice President for Health Equity and Inclusion. And in that role, I help develop and lead our Diversity and Inclusion Strategic Plan, which has 3 objectives to create an inclusive and equitable campus climate, recruit, retain, and develop diverse communities, support innovative and inclusive scholarship and teaching. And I was responsible for implementing that plan throughout the entirety of Michigan Medicine, which is about 40,000 individuals with 200 distinct units in their own plans. The other challenge, which gets to your last question, is that people don't realize that often when you're at a large academic institution like Michigan, that you're leading staff and balancing a budget. So I lead a staff of 20 individuals with 16 staff and 4 faculty. We have numerous programs and initiatives that we align with our academic medical center's vision, mission, values, and priorities. Numerous pathways programs. I've developed our faculty leads in all areas of the pathway of pre-med, medical student, resident, and fellow, and faculty. And each of them are responsible for advancing diversity, equity, and inclusion with 5 major areas: recruitment and retention, leadership, professional development, mentorship, coaching, and sponsorship, and networking, community building, and wellness. Our staff also serves many roles within the institution, including diversity consultants. We're providing guidance, we're delivering trainings, we facilitate group sessions, we help develop metrics and a dashboard to track what the work we do. We've also developed numerous tools, including how to guides about facilitating challenging conversations. So one of the things I was frankly shocked at after the George Floyd killing, that a lot of major leaders didn't even know how to start the conversation. So we had to do things like that to help facilitate things. We also developed a faculty search toolkit, and I lead our anti-racism oversight committee. Since Michigan has a law that doesn't allow us to target any underrepresented groups, we've had to become very innovative in our work. And so there's a lot of innovation involved with this. Another thing is that with our work, there's a lot of collaborations and relationships with other groups, because in order for diversity to be successful, it can't live with one person or one office. So I have strong collaborations with human resources and faculty affairs, admissions, GME, quality, safety, the medical group, and others. And I participated in philanthropy things and all these things to help us as an academic medical institution. I'm involved in recruitment, retention, equity issues, patient bias and racism issues, and I'm one of the leaders of our culture change group. I have to say that this is the most stressful job I've ever had and the most rewarding. And to address the last part of your question, the glass ceiling, I agree that this can be a major issue. In fact, when I was considering this role, one of my mentors at Michigan told me to not do it because it's a dead-end job. And I have to say, I didn't believe him at that time, and now I see it more. The reality is that most diversity, equity, and inclusion deans in medical schools last on average from 3 to 5 years. And those who stay longer don't usually have upward advancement. Most outside individuals feel that all we do is implicit bias and diversity committees. People don't realize the complexity of the jobs, the reality that we do operations and all these things. So it's hard to advance. For medical school leadership, if you want to advance, if you want to be a dean, you have to continue to publish. This is one way of doing that. But it's challenging because we're pulled into so many things in so many directions. Other options include hospital leadership, but you need operations experience, which I get. You also need profits and loss experience, which it doesn't really exist in my space, but I'm trying to obtain. And one of the things I recommend if you're considering a job like this is to talk to your leadership and mentorship about future opportunities. That's what I'm doing now. And realistic opportunities include being a chief medical officer, a dean, office for patient experience, a quality officer because of the healthcare equity issues, professionalism, like Dr. Friedman in Baylor, and culture change leader. So yes, it is a glass ceiling. However, I think that we can be innovative and work with our leaders and let them know that to help us break that glass ceiling. So thank you for that question.
Thank you, David. And you guys are doing a great job. Oftentimes when we look for guidance on diversity issues, we look at the University of Michigan. So thank you for that work. Howard, I know it's impossible to look into the future, but what do you think the future holds for diversity in otolaryngology? Has your institution come up with a target goal for underrepresented minorities? And are these targets aligned with a percentage of the population represented by these minority groups? Or are you using other metrics? So what do we expect 5, 10 years from now?
Well, can you hear me?
Yes.
Yeah, I'm sorry about the technical issues. You know, I think that what we're working towards is a representation of the population that we are serving. I think our institution is working towards that, but you know, this is a process that that has been accelerated after the murder of George Floyd. A very detailed strategic plan that was cross-cutting, really across all domains of the institution, was conducted, and resources were put behind the resulting strategy, as well as a new hire in the form of a vice dean. And so this hire has just been, search has just been completed, and so the implementation of the strategic plan is certainly in its early phases. But I would say that our specialty, if I can speak to otolaryngology more specifically, you know, has been somewhat late to the party. But I am optimistic that, you know, that if we are persistent and use multiple tactics to address the limited pipeline that we really haven't cultivated sufficiently, that if we work on that from multiple vantage points, that we're going to continue to see improvements, and I think we're starting to see that. Really, potentially the greatest opportunity to impact population health and gain financial savings for our health system in a value-based care system is to address disparities in health outcomes. If that's what it takes to make this happen, of course, it's also a question of equity. It's a question of fairness and justice as well. As a specialty, we lack really sufficiently, we just lack sufficiently diverse workforce to really solve. I don't even think we have fully characterized the disparities in our specialty to the extent that we could. But I think diversity is more than just a number. You know, I think that it's also a litmus test for tolerance of difference. And it's also a litmus test for level of psychological safety in the workplace. And our workplace is a place of service. It's also a place of innovation. And you know, psychological safety is an important characteristic of innovative environments in which people can bring their most authentic selves, be vulnerable and take risks. And that's what it takes to really innovate. That would be, you know, my primary issue. Now, in 5 to 10 years, you know, I think it's going to be a slow process. The change will be fleeting, but and hopefully not fleeting. It will hopefully be permanent and it will grow. But it will be fleeting if we do not sufficiently commit to really an intentional sponsorship of more diverse leadership in our field. And we have to be willing to take risks. You know, we're very we have some difficulties taking risks on people that don't fit a particular mold. We really need to take more risks in mentoring individuals from a variety of backgrounds in order to really overcome this issue. So anyway, that would be my thought for now.
Thank you, Howard. Jesus, so before we can turn medical students into otolaryngologists, they have to get into medical school. So can you describe some of the efforts that are being made as Dean of Admissions to increase the number of underrepresented minorities in medical school?
Yeah, so, you know, Tulio, we have been looking at this for a very long time. And I like that the previous panelists introduced the word pipeline, because we all talk about the pipeline, right? And where does the pipeline start? You know, we effectively have, you know, concluded that if you start working with the pipeline during the pre-medical years, you're a little bit late to the party, because it seems to me that the pipeline becomes leaky during those years, because many of these you know, underrepresented students may not be prepared to really, you know, survive the rigors of the pre-medical curriculum. So really what we've done at Baylor is we started partnering with middle schools and high schools to be able to catch them really early on. We have a lot of summer programs. We have programs called Doc Prep. And these are all high school students, and they come to Baylor and they spend 2 weeks. This is prior to COVID, right? And they get introduced to people that look like them. They're physicians. They share with them, you know, what was the journey to medical school? What did you do? And a lot of them, you know, realize that, the chief of infectious disease at the VA is no different than them, that he had the same upbringing, the same background, right? So we started at that point, you know, so that by the time they get to high school, we have a better handle. By the time they get into the undergraduate years, they're better prepared to be able to do that. So pre-medical experience, I think if you start there, you may be a little bit late to the party. You got to start much, much earlier. As a medical school, you know, we have to have, you know, faculty also that look like the students, right? Because we all know that a diverse faculty facilitates the recruitment of students, of medical students, of residents and fellows, and really plays a pivotal role in their education training. And it fosters an environment that is conducive to advancement and development. And that is really needed, right? You know, so we also looked at partnering with, pipeline programs such as BSMD programs. We have one BSMD program with Xavier, Louisiana, which is a historically Black college. You know, we get students that have a conditional acceptance to Baylor College of Medicine. We have a partnership with St. Mary's University, that is a Hispanic serving institution in San Antonio, Texas. They also have a conditional acceptance, you know, to Baylor College of Medicine. The state of Texas sponsors a program that's called, the acronym is JAMP, that stands for Joint Admissions to Medical School Program. They take students that are underrepresented and they are from disadvantaged backgrounds, and they also have a conditional, you know, acceptance to Baylor, and we have about 5 of those students. The other thing that we also need to remember is that, you need to have a really strong recruitment program. But not only do you need to recruit them there, once you have them there, you need to have a really, really good retainment plan, meaning you need to have really strong, academic support services. When we talk to students and we ask them, what are the kind of things that you're looking for in a medical school where you think you'll be successful? The first thing they tell, especially students of color, they say, we need a school that has a culture that works and it looks diverse and the workforce is diverse. Number two, we want strong academic support services. And number three, we want financial aid. And financial aid can come in the form of need-based scholarships. It can come in the form of merit-based scholarships. The one mistake that you don't want to make is that you sort of use scholarships to increase diversity, because at some point, those scholarships are going to dry up. And so will your pipeline of diverse students, because the only thing that you were doing to recruit students is giving them a full ride. But if you basically give them financial aid, you give them a climate in which they can develop and advance, and you give them, the academic support, they might be able to overlook the financial aid and said, this is a place where I can be successful. And therefore this school is going to, rise to the top of my list. The other thing that most medical schools, and we have done and used very successfully, is the concept of holistic review, right? Where you balance the applicant's attributes, metrics, experiences in order to mitigate the biases and the previous dominance of academic metrics in making admissions decisions. But you have to remember that in order to be able to do that, you have to culture and nurture this diverse applicant pool that's coming into medical school. Because if that pipeline that's coming is not diverse, it doesn't matter how holistic your review process is and how unbiased it is, you will not have a diverse class because you don't have a diverse pool. So again, these are the kind of things that we've been working on, for the last couple of years. And I'm happy to say that, in 2020, 25% of the medical school, the entering class at Baylor was underrepresented in medicine. And last year, it was almost 33%. And, we had, in African Americans, we had a 22% increase from entering year 2020 to 2021, and about a 15% increase in Latinos. Again, the pool is very fixed. So with all the medical schools, going after the same, students, you really have to do something else than throw money at them. You need to show them that you have the climate that is there for them to grow and develop, that you have the faculty that look like them, they're going to be able to mentor them along the way. I think those are just as important as having financial aid, packages for them.
Thank you, Jesus.
There's just one quick follow-up question, and then Dr. Carrie Francis, we have a question for you. But for Dr. Vallejo, can you tell us a little bit about how you use those strategies to create a welcoming climate for applicants who are underrepresented in other ways, LGBTQ students, students who are of different linguistic backgrounds, socioeconomic backgrounds, and things like that? So, it's that happens at the time that the students come to interview. So we partner with the provost of diversity, equity, and inclusion at Baylor. She has an ambassador group in every faculty members in every department of the medical school. So at every interview session, we have several ambassadors, faculty members, students, and fellows come and talk to the students so that they know that there are people that actually look like them, right? Because the medical students, when they come to review, they basically stay in the medical school. They don't venture out to the departments. They do, tour the hospitals, but they don't get to see everybody. So we make an effort to bring those people to them, to be able to see that what we're actually telling them is actually true, that there is diversity in the medical school, not only in the class, but also in the clinical departments, in the basic sciences department. So that's how we sort of, share that with them. Thank you. So So for Dr. Carrie Francis, beyond ad hoc mentoring, and once you have trainees and faculty from underrepresented groups in your program, what sort of structures are really important in supporting and empowering them as they develop their careers, and what sort of innovative strategies have you found useful in that?
Yeah, thank you for that question. And before I start, I do just want to congratulate Dr. Vallejo. That's not what you described with your medical student class is super exciting. So congratulations on that work that you've done and the results that you all have gotten. So, Karthik, what you're describing is really workforce development, which is really grounded in the idea that policies and programs will develop an institutional culture that provide individuals with opportunity and growth and support for growth. And that it also supports an organization's core values and an institution's missions. And so that is really the core of the work that I do at KU in Faculty Affairs and Development. And having started my leadership career in undergraduate medical education with our first and second year medical students, third and fourth years, and developing some of our learning communities, what I've realized is that the academic faculty career really accelerates in medical school. And so when we're thinking about leveraging the academic faculty life, we have to think earlier and sooner than our residents and trainees. It's important at all levels. You've heard the discussion about the pipeline from all of our panelists, and I think we'd all agree that all segments can be strengthened, but I really feel like it accelerates there. And as we want to recruit more faculty who are underrepresented into academic medical centers, it's really important that we start soon, that we start in medical school where it really accelerates, and then able to translate that into strategies throughout the continuum. And so one of the things that we're really focusing on, I think a lot of faculty development programs have focused around skills development, leadership skills, manuscript writing, grant writing. Those are all important areas of development, career growth, teaching education, and even curriculum development. Those are generally parts of what is required for promotion and tenure. So that is something that we definitely reinforce. We work with our URIM faculty, and we've developed programming that has an intentional focus for our URIM faculty. The other element that we think is truly important and probably not evaluated enough or developed enough is around the psychosocial needs that are also important. When we talk about thriving, we don't thrive with just skills and technical skills or even knowledge. We thrive with supportive environments, as Dr. Francis has already mentioned. We thrive with peer networking and coaching, as Dr. Brown has mentioned. We truly are working to cultivate a sense of community, and that allows faculty to mitigate experiences of social and professional isolation, because that tends to threaten our URIM faculty's vitality. And so we really want to focus on how we can cultivate that community. Dr. Brown also mentioned wellness, and that's another very important aspect of what we're looking at. We definitely work with our faculty to create self-care strategies at work. We all have bad days right now, or in the last 2 years. We're in the time of COVID and things are rough. And so what we've tried to do is fortify our faculty with techniques and opportunities that they can come together and really mitigate elements of burnout just through fortification, and also through having a sense of community and a home where in the environment that we've created, we've really tried to cultivate that well. And then a third area that we really focus on is personal positioning. We want to expose the hidden curriculum. We have built a journey map for our URIM faculty so that they are able to develop 1, 3, and 5-year goals that are aligned with their vision, values, and purpose. As academic faculty, we are citizens of the academic medical center. So of course, there are responsibilities that we have simply by being a faculty member. But we really want our faculty to take a step back and think about, okay, it is required of me to do A, but what skills am I going to get from this that are going to help me move forward with my dream, with my vision, with my 5-year plan? And so those are 3 core elements that we are using to help our faculty grow. And those are the same elements that we are leveraging for our trainees. We're trying to build a program that allows our trainees to work through some of the same elements that we're using with our faculty. And we really want to take that into maybe a 3rd or 4th year, or rather 4th year medical student elective, where we can really start to grow academicians as soon as we can. The benefit, I think, is really the innovation that we've talked about so far. You know, there are no non-qualified, I mean, when we think about who's qualified or who's not, there are qualified people out there. There are faculty who have the skills necessary to be successful. There's no lack of talent. What is often different is just the development of URIM faculty and how that fosters success. And so we're very intentional about our programming, as well as how we evaluate it, the metrics we're developing and the way we're able to evaluate what we're doing beyond satisfaction. It's hard to leverage satisfaction into a budget line. It's a lot easier to leverage outcomes, data-driven outcomes into a budget line.
Thank you.
Thank you, Karen. That was great. Really an impressively integrated kind of sequence of efforts that we can definitely learn from. So at this point, we wanted to leave a little time for the panelists to talk with each other, but also for the audience to dive in and ask questions. So please feel free to put your questions in the chat or to use the raised hand thing on Zoom, and we can hopefully have a bit of a discussion.
I think if there's no questions, I'd like to comment on something that we all mentioned, the pipeline. And I would love to like reframe how we think about the pipeline. I've always been troubled by the fact that we call the pipeline leaky, because this implies that people are falling out. And maybe there are some cracks in the pipeline, but I have the theory that the pipeline could be clogged with crud and other elements. What I mean by that is that there are biases and including systemic racism that contribute to the clogging of the pipeline, and therefore not allowing people to flow through. And when I talk about systemic racism, what I mean is the policies, practices, and procedures that impact individuals from thriving, as Dr. Francis said, and be able to take advantage of the goods and the services in an equitable manner. And we can look at it from the entirety of the pipeline, from when people are in high school or in elementary school. If you're, you know, the quality of your schools are based on the wealth of your tax base. So if you're poor, your public schools are often lower quality. If you don't have safe housing, running water, like in Flint, clean water, like, you know, and food insecurity, how are you going to have great nutrition? In college, you know, we know that standardized test scores are related to the wealth of your family. And we also know that, you know, there's legacy individuals who get into school at a higher rate. And many people feel that this is a practice to perpetuate a similar type of student body. And in medical school, like Dr. Carrie Francis mentioned, there's the hidden curriculum that not all minority students know about. I have underrepresented students come to me within the first few months of medical school saying, I have classmates who already have amazing research projects. How did they ever learn about them? I had no idea that you even need to do research to go into otolaryngology. And then as faculty and residency, you know, we look for super high board scores, which that's just one predictor. And for faculty issues, like Dr. Francis said, you know, not everyone is developed, not everyone has mentors, not all the work that is being done for diverse equity inclusion is counted for promotion, and people are not being, even at Michigan, we have data that women and underrepresented minorities are not nominated for awards and put on committees as they feel that they should be. Also, healthcare disparities until recently wasn't well valued by the NIH. And so I would ask us to reframe the pipeline about what are the clogs in the system and how can we individually and as groups look at the policies, practices, and procedures and our biases and be enzymes to dissolve the crud blocking the pipeline. And I assure you that I'm not sponsored by Drano.
Jesus, I have a question. You're also the co-director of the physician scientist program. That's an area where there's definitely been a lack of presence for underrepresented minorities. Can you elaborate more on the efforts trying to help that pipeline?
Yeah, so I'm the co-director of the clinical scientist training program, which is mostly MDs, right? Trying to get either a master's in clinical investigation or a PhD. But I work very closely with Sharon Plon, who's the director of our medical scientist training program. So we have a lot of discussions, so I can tell you what they're doing. They have a T32, right? And so obviously now the NIH is very interested in diversifying not only the physician workforce, but also the physician scientist workforce, right? And you need to understand that if the pool just for the regular MD, candidate is small, you can just imagine what it looks for the physician scientist, right? Baylor does a very nice job of interviewing a lot of URMs for their program, and they go out of the way to have sessions, showcasing what the school has to offer. They have all the affinity groups at the medical school come and basically tell the applicants exactly what it is to be an underrepresented student at Baylor in the medical scientist training program. And if you look at the numbers of offers that they make and the acceptance that they have, the number of matriculatings, it has been really, really low. They do, obviously, because they make more offers to African-American or Hispanic students, that looks like it's a little lower than when you make offers to 5 URMs and you get 2, it looks great, but still the numbers are pretty small, right? But now they're beginning to do more and more to try and increase the number. Just recently, the Medical School Admissions Committee and the Medical Student Training Program got together because they're ready to make offers, and they made, I think it was something like 19 offers, and 50% of those offers went to URM. So again, they are making a big effort to diversify the physician scientist workforce also.
Dr. Brown, I'll say I appreciate your comment about the pipeline and how we frame it. There is more oppression than there is underrepresentation that exists in academia, and the way that we use our language really contextualizes the outcomes. And so it's one area that I do take very seriously and think a lot about how the words that I use, the language that I use, because consciously or unconsciously, it directs my actions. And so I appreciate you bringing that to our attention and asking us to reflect on it.
I have a question for all 4 panelists, and please feel free, any of you, to jump in. Most of us do not have formal leadership roles in terms of diversity or equity or inclusion. So as folks who have those sorts of formal roles, what sort of support or participation do you look for, and do you hope for from all of the rest of us?
Do you mean like resources and support that would help a person in that role be successful?
I guess both. Sorry, that was a poorly worded question because I just thought of it. But part of it is, how can we all help folks in those roles succeed? But then also, how can we help you accomplish the mission for which you took that job? I mean, it's not just on you to do that, it's on all of us. So
yeah, maybe I could pick up on that. It's not just on you. I mean, I think it's really something that needs to be integrated into the life of the of the department or whatever the entity is. And those individuals should be seen as very valuable resources to leadership, leadership at the chair level, at the chief level, etc. As we think about all three missions, how do we address the reality that we're serving a diverse population? So as we look at the questions that we're trying to pose around the causes of disease and the solutions, how do we make sure that we actually are looking at a lens that takes into consideration that the full scope of the population? As we think about recruitment of residents and or faculty, are we indeed considering all the talent that's out there, and how do we mitigate the intrinsic structures that limit our ability to be as inclusive as we can be? I think the tendency over the course of my time, as a student and trainee, and then as a resident, has been that the diversity efforts have been delegated off to the side as something that you sort of feed in money to, and you sort of let it do its thing, and then but business as usual otherwise. And I think that that has had very limited success.
I also think these efforts, what we've talked about, can seem overwhelming, particularly, I think to your point, Karthik, if you're not in a particular role. But I always ask people to think about what impacts you can make where you are. We are not all Dr. Brown, and leading the health system in strategic planning around diversity, equity, and inclusion, or even myself or our, 1,000 to 1,200 faculty members. But we all have some impact and some leverage in our environments. One simple example within our otolaryngology department is, over the last year, we've incorporated health equity into our PSQI reporting process, as well as our M&N conferences. And so small things, because we're talking about our patients, because we're talking about patient safety and quality improvement monthly, there are small areas where we've been able to create ideas. We've been able to have, as Tulio mentioned earlier, this virtual think tank where we are now creating interventions. So from our health equity lens, from our PSQI, we were able to identify trends in hypocalcemia post-thyroidectomy. And so small changes, well, big changes, but they are smaller than, I think, when we try to solve the problem of underrepresentation, is to work with our pharmacists to provide calcium prescriptions to our patients before they leave the hospital, so they get a month's supply. Now, yes, that took some time to put in place, but it was an area that we could easily, that we could see as something that was close to home, and an opportunity for us to impact our patients, not just individual patients, but in looking at a 3-year history of hypocalcemic events and really using an equity lens on where are pharmacies, where are our patients who are having these complications living, what are the barriers that they experience. We've been able to intervene in a way that is impactful. And so I think starting where you are is a great place to start.
Thank you, Carrie. That was really, thank you very much. I just tying to that, maybe Max Kligerman, who's one of our chief residents, has a question. Max, can I call on you?
Sure. Thanks, Dr. Balakrishnan. Thanks, Dr. Francis. Tying into what you were just saying, I guess I'm wondering about ways that we can better advocate or counsel in our one-on-one patient encounters for patients from underrepresented minority groups who we know there's tons of data to show adverse or worse outcomes. And I know we spent a large portion this evening talking about systems level ways that we can kind of improve that. But I'm wondering, in that one-on-one encounter, are there things that I can do or we can do a better job thinking about to try to advocate for our patients?
I can start with that. We spent a lot of time after the George Floyd incident as a leadership team at Michigan Medicine going into our diverse communities and actually talking to them and asking them about their experiences and how they perceive our medical institution. The top thing that all of them said is that they don't feel heard, they don't feel listened, and they don't feel believed. In fact, many of them said, I bring an advocate with me just to reinforce what I'm saying. And so the very first thing that you could do is listen and value what they state and build trust, and then practice cultural humility, which is understanding your biases and putting them in the driver's seat, the other person in the driver's seat as the teacher, and learn about their identities and what's important to them and what's going to make their experience better. For me, diversity, equity, and inclusion is about lifelong learning. I'm learning every day and I'm humbled every day. So we have to practice that humility. And if you were to do one thing, it would be listen empathetically and really at the end of your visit, ask yourself, did I address the needs and the concerns of this patient?
Dr. Stankovic has a question.
If I can add on to that quickly before we move on, particularly for our trainees, think about when we all were medical students, because our brains think in processes, right? We're doing an HPI, we're doing a physical exam, we're creating an assessment and plan. When we were medical students, the area where we were able to show off often was getting that social history, right? And so I think that's a great place when you're thinking about where do you put in place what Dr. Brown is talking about, listening, how do you listen, and where do you learn more about who your patients are? Because we're no longer treating bodies, we're no longer treating disease, we're treating lives. And so that social history is that area in your brain where you're doing social history is a great opportunity to learn about your patients and learn what challenges they see, because the challenges they see may very well be different from the challenges you think they face. There are structural vulnerability tools that you can use that can provide you with some prompts. Frankly, the structural vulnerability tools are what we've incorporated into our PSQI reporting form, but those are great areas for you to kind of add on to your day-to-day interactions. The iceberg exists where the individual is sort of the outcome of a lot of systemic processes. So oftentimes we have to layer that onto our individual encounters.
Thank you both so much.
So Dr. Stankovic has one question, and I think after this we can wrap up our discussions.
Yes, I just want to thank all of our distinguished panelists, as well as Karthik and Tulia, for organizing this really most stimulating and illuminating discussion. We definitely look forward to continuing to work with you to overcome these visible and invisible barriers as we aim to make our environments more diverse, inclusive, equitable, and enjoyable for all. Eliminating suppression and biases also creates a much healthier world. And we as physicians are obliged to make the world healthier, and we should be leading that initiative. So thank you again. This is only the beginning of our long-term friendship. We very much look forward to your insights and guidance, and working together, we can make the world a better place.
Thank you very much for your participation.